हेलो पुनीत जी।
सर गुड आफ्टरनून। नमस्कार।
गुड आफ्टरनून। ये टोपी पहने हैं?
हाँ सर,
क्यों?
ऐसे ही। आप कैसे हैं सर?
ठीक है, ठीक है, ठीक है।
अच्छा, जी।
ये आप सोए हुए हैं क्या?
नहीं नहीं, सोए हुए नहीं सर, आराम से छुट्टी मना रहा हूँ सर, तो इसलिए बेड पे
ओ,
बैठा था।
ओ
अब
अच्छा
बैठ
अच्छा अच्छा। अब घर पर है।
कैसे चल रहे हैं सर? कोर्सेज सारे बढ़िया चल रहे हैं?
बहुत अच्छा चल रहा है, बहुत अच्छा चल रहा है। आप लोग कमाल कर दिए मुझे। हम तो हर दिन नहीं रह पाते हैं, क्योंकि दूसरे काम में भी थोड़ा व्यस्त हो जाते हैं, लेकिन
जी।
बहुत अच्छा चल, बहुत
बढ़िया।
प्रशंसा हो रही है।
आपकी इतनी प्रसिद्धि है कि सब आ गए हैं गेट में।
अब तो पैरवी आता है कि सर हमको भी दिलवा दीजिए, हमको भी दिलवा दीजिए। तो आपको एगो पैरवी हम किए भी थे।
तो सारे सातों दिन ऑक्यूपाइड हैं सर?
हाँ, 7 दिन एक्सपायर्ड है, 7 दिन।
जी
और बहुत अच्छी तरह से,
जी।
बहुत अच्छी तरह से। बिगिनिंग आप ठीक करते हैं मंडे को, तो सब 7 दिन हमारा ठीक जाता है।
अरे नहीं सर, विद ऑल योर ब्लेसिंग्स इट्स गोइंग ओके।
आज विद्यार्थी सब अभी नहीं दिखाई दे रहा है। ओ 22 22 जो है।
22 जने हैं सर, आएंगे
हाँ
सर 5-10 मिनट में आ जाएंगे, अभी सारे ज्वाइन करते रहते हैं।
हाँ हाँ हाँ। कुछ विद्यार्थी है कि सब दिन रहते हैं सातों में, मुझे ना
जी।
देखते हैं कि सातों जगह हाजिरी बना हुआ है उनका।
हाँ सही है सर। तो सर बढ़िया है बहुत, एक्चुअली 1 घंटा दिन में निकाल रहे हैं तो सारे सब्जेक्ट पढ़ रहे हैं सर आराम से।
हाँ 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 हाँ।
सबके तो सर्टिफिकेट मिल रहे हैं और सारे सब्जेक्ट पढ़ने को मिल रहे हैं सर।
नेट में कुछ गड़बड़ाया हुआ है।
स्क्रीन दिख रहा है सर हमारा?
हाँ, दिखा दिखा। ड्रग थेरेपी फॉर मैनेजमेंट ऑफ डायबिटीज पार्ट 1।
जी राइट सर। और सर कॉन्फ्रेंस की तैयारियां ठीक चल रही हैं सर?
उसकी मेहनत लग जाती, तैयारी शुरू है, उसकी भी तैयारी शुरू है।
जी
जाना है, ट्रेड वालों की मीटिंग बुलाए हुए हैं।
जी। तो हमारे लायक कोई काम हो तो बता दीजिएगा सर।
आप ही से शिक्षा लेना है, काम क्या है? शिक्षा आपसे लेना है, ये कैसे होगा?
नहीं नहीं, अरे सर आप कोई भी मतलब राजस्थान में या कोई भी कोई और भी कोई काम हो सर कहीं भी, तो इफ आई कैन बी ऑफ एनी हेल्प।
बता देंगे,
जी
बिल्कुल
जी
बता
सर
देंगे।
जी जी।
और गाइडेंस तो चाहिए ना आप लोगों का।
अरे नहीं सर, हम तो कहाँ गाइड करेंगे, हम तो आपके साथ वर्कर हैं सर।
अनुभवी है, थोड़ा अनुभव तो है ना।
हाँ अनुभव तो है सर।
होली के बाद लड़का सभी छुट्टी मना रहा है।
हाँ सर, सब जने अभी छुट्टी पे हैं, वही मोड लग रहा है सर, अभी 30-35 जने ही हुए हैं सर अभी।
हाँ हाँ हाँ। हमारी किताब लिखा जाएगी, इससे बताइए।
सर किताब में लिख तो सकते हैं, बट क्या है कि सर इसको ऐसा जितने पावर पॉइंट है इसको सारा उसको वर्ड में लेना पड़ेगा एक्चुअली।
हाँ हाँ, थोड़ा मेहनत तो होगा।
मेहनत तो काफी होएगा सर उसमें, फिर वो क्या है कि वो पूरी सर ये पूरा बुक ही निकल जाएगा। जैसे डायबिटीज का एक कोर्स है तो शॉर्ट सर्टिफिकेट कोर्स के नाम पे एक किताब मॉड्यूल निकल जाए पूरा, तो उसमें सब चीज कवर हो जाएगी। तो कर तो
तो
सकते हैं, कर तो
हम चा,
सकते हैं।
हम चाहते हैं कि निकल जाए। स्पॉन्सर हम खोजे हुए हैं, मुझे ना।
तो सर मैं तो आपको मैं भेज दूंगा सारे लिख करके, सारे जितने चैप्टर है सब।
तो ठीक है, मेल पर भेज दीजिएगा तो हम निकाल के ही करा लेंगे।
ठीक है सर, मैं भेज दूंगा राइटअप सबके।
हाँ हाँ हाँ, करा लेंगे करा लेंगे।
बीच में सर कहीं बाहर जाए, आप बाहर थे इंडिया से?
हाँ
इंडिया से बाहर गए हुए थे सर कहीं?
हाँ, वियतनाम गए हुए थे।
हाँ, मैं फेसबुक पे देखा था फोटो आपके, हनोई के फोटो डाल रखे थे आप।
भाभी थी, साथे थी,
हम्म।
गए थे हम लोग। थोड़ा बहुत जाना चाहिए बाहर,
हाँ नहीं ठीक है सर, ठीक रहता है बीच बीच में।
बीच बीच में भागते रहना चाहिए।
हाँ सर।
अब अप्रैल में हम लोग जंगल सफारी करेंगे, हैं?
हाँ सर, अप्रैल में जंगल सफारी है सर इस बार। तो सर आपकी प्रेसिडेंट प्लेस मीटिंग रह गई थी, अब आप डीन प्लेस मीटिंग कर लीजिएगा सर।
कर लेंगे, कोई दिक्कत नहीं है सर।
हाँ, वैसे कह
कर
रहा हूँ
देंगे।
हो गई।
कब करें ये नहीं समझ में आ रहा है, कब करें,
हाँ हाँ,
क्योंकि
क्योंकि यार व्यस्त भी, हाँ बीच में व्यस्त बहुत हैं आप, तो वो थोड़ा सा
सितंबर में तो हमारी गवर्निंग बॉडी की मीटिंग करना है हमको।
उसी में सर एक दिन एक्सटेंड कर लीजिए कहीं, और रख लीजिए नेपाल नेपाल एक दिन के लिए और एक्स्ट्रा, या कहीं कोई तो बढ़िया जगह पे बिहार में कहीं भी अच्छी कोई जगह और साथ में।
नहीं, हम राजगीर राजगीर में प्लान कर रहे हैं कि राजगीर में मीटिंग कर रहे हैं।
हाँ तो राजगीर बढ़िया जगह है सर, बहुत गया और बहुत गया और सारे सब सारे बढ़िया
और
रहेगा।
सब सब घुमा देंगे, सब घुमा देंगे, यही प्लान में भी यही है हमारी, बुझे
जी
ना।
जी जी।
प्लान में यही है, क्योंकि पटना में देखना क्या है, पटना में कुछ है नहीं कि देखें।
हाँ पटना में कुछ नहीं है सर।
और कंस्ट्रक्शन तो हमको जमीन पर बनाना है,
जी
इसलिए वो
जी,
तो अभी कुछ देखना नहीं है।
सही बात है सर।
कि राजगीर हम ले चलेंगे, दिमाग में यही आ रहा है।
हाँ तो वहाँ फ्लाइट भी है सर, राजगीर में डायरेक्ट आती है फ्लाइट
नहीं,
से।
पटना से उतारेंगे चाहे गया से उतारेंगे, और
हाँ
गाड़ी देंगे 2 घंटा में
हाँ
राजगीर।
हाँ, वही तो कह रहा हूँ सर, गया से तो गया तक तो फ्लाइट जाती है सर।
हाँ, गया पटना दोनों जगह आती है, वहां से बाई रोड जाना होगा।
जी
थोड़ा टाइम ले लेंगे, बहुत हड़बड़ी नहीं रखेंगे।
जी।
और वहाँ राजगीर बोध गया सब घुमाते हुए नालंदा मीटिंग को हम आगे कर लेंगे।
जी करें, स्टार्ट करें सर।
हाँ, 40 हो गए।
हम्म।
Now, good afternoon. Now we are going to start the session post-Holi, and I will request Dr. Puneet Saxena to start his lecture. Dr. Saxena, please.
Right. Thank you very much, sir. Dean ICP Dr. Kamlesh Tiwari, who has been running these courses very nicely thought of, and as we were discussing that these programs are running very nicely right from Monday to Sunday, and the students are getting benefited from these programs. But today I see probably a little number of attendees, because probably post Holi people are still in holiday mood, and we are moving on with the diabetes short certificate course here, and we have up till now discussed the introduction and the historical background of diabetes, and followed by the etiopathogenesis and classification of diabetes. And after doing that, in the last module we had a discussion on the diet and the exercise and the lifestyle management of diabetes, which is an integral part of the treatment, or you can say the management of diabetes, or rather it's the first step, or it's a step which should run throughout the course of management. You cannot undermine the importance of diet, exercise and lifestyle. But beyond that, if somebody is not having glycemic control or having complications or comorbid conditions, then the medications are required, and we should know that how best we can manage the diabetes. So we are moving on to drug therapy for management of diabetes, and today is part one, and I am going to take the almost the oral medications for diabetes, and in the subsequent module we will discuss about the insulin part, basically, where it's used for type 1, type 2, or any other emergent situation for diabetes. So what are the treatment objectives? Basically treatment objectives are the correction of acute metabolic abnormalities, where the glucose, high blood glucose in itself is an acute metabolic abnormality, ensuring long-term maintenance of glycemic control to prevent chronic complications, identification and treatment of comorbidities, educating the patient regarding the disease and maintaining a high level of motivation. The management of diabetes has moved from being glucocentric to focusing on cardiorenal risk factors such as hypertension, dyslipidemia, obesity, tobacco use, harmful use of alcohol, and the term has been coined as the CKM syndrome, right? So the cardio kidney metabolic syndrome. So from and we are not far away when we will go on adding other risk factors also, where fatty liver or liver failure because of the involvement what do you call it as the MASLD, that is the metabolic associated liver dysfunction, will also be added in the management of diabetes. So apart from glucose control, all these factors needs to be addressed. Why do we need to treat diabetes? Because it's a leading cause of end-stage renal disease, one of the major cause of blindness, leading cause of non-traumatic lower limb amputation globally, and a cardiovascular risk equivalent. It's leading cause for peripheral arterial disease. It is leading cause for stroke. So, and it's a very common comorbid condition with hypertension and obesity, which is leading to the maximum morbidity and mortality globally. So, how the treatment has evolved? It is all started with insulin, right? And we all know that insulin was first put to use in 1921, and the early years of insulin, the aim of treatment was to keep the patient alive, especially the type 1 children. And you can see here this is the patient of the the first patient who took the insulin, and how they were cachectic, and then after insulin therapy they gained weight and they survived, and the growth of these children, it improved with the usage of insulin. So at that time, the extract of insulin, which was taken out by the Banting and Best and McLeod's, was being used, and later on the refinement of treatment has moved on, whether you talk about insulin or the oral hypoglycemics. But is this only sufficient to prevent diabetic complications? Here is a famous quote by Elliot P. Jocelyn, who was a leading diabetologist from USA, and he said way back that the aim of treatment of diabetes is to bring blood glucose as close to non-diabetic state as is feasible. And even so, the concept of diet control blood glucose remains debated till 1990s, since tests for assessing long-term glycemic control such as HbA1c were not available. So he professed that you should achieve normoglycemia, but there was no standardized test to assess normoglycemia except for doing the urine glucose in the older times and the blood glucose in the fasting and the postprandial state, followed by newer parameters like HbA1c, and nowadays the glycemic variability and time in range, time above range, time below range. There are so many parameters to assess the glycemic control. Why this was professed, and it was professed and it was just taken to task by the trials later on. Can diet control of blood glucose prevent diabetes complications? And the landmark clinical trials were done, and you all know that DCCT, which was done in type 1 diabetes, and the UKPDS in type 2 diabetes, and both trials compared the benefits versus risk of diet glycemic control as compared to conventional glycemic control on the development of diabetes complications. And the results of these trials, they came out, and they were the landmark results, and they were published in the New England Journal of Medicine. And the diet control does matter, as you can see in the graph over here, the DCCT results that which was done in the type 1 diabetes. And you can see here that as the HbA1c is increasing from 6 towards 12, the microvascular complications like retinopathy, nephropathy, neuropathy, and presence of microalbumin in the urine is going up and going up exponentially at the extreme end of HbA1c. So lower the HbA1c, the less is the chance of developing microvascular complications was established by these trials. And you can see here the data from the UKPDS, which was done in type 2 diabetics, that lowering of glycosylated hemoglobin by just 0.9%, or you can say 1% roughly, can achieve risk reduction of 12% at any diabetes related endpoint and any microvascular endpoint by 25%, can reduce myocardial infarction by 16%, retinopathy by 21%, and albuminuria by 33%. Sorry. Yes. So, uh, both type 1 and type 2 diabetics, they were benefited by diet control. And in both these trials, the intensive control arm achieved an HbA1c close to 7%, and with this level of glycemic control, significant reduction was noted in the risk of developing microvascular complications, that is retinopathy. But there was no significant reduction in cardiovascular endpoint which was observed in these. Although you saw that in UKPDS, the reduction in myocardial infarction was to the tune of 16%, but p-value was not significant. So the later trials, like the advanced trial, the VADT trial, the ACCORD trial, they were commissioned basically to see the benefit of intensive control on cardiovascular outcomes. However, the ACCORD trial was prematurely terminated because of excess mortality in the intensive control arm because of the hypoglycemia which was created and which basically balanced the benefits of intensive control. However, in advanced and VADT, no significant benefit of intensive control on cardiovascular outcomes. So these studies were conducted in older patients with long duration of diabetes and high cardiovascular risk, and probably that was the reason. And the the occurrence of hypoglycemia with too tight control, especially in the older and the sick people, offset the benefits of tight control. That probably was the reason. But tight glycemic control is required to reduce both micro and macrovascular complications. Now, the UKPDS follow-up study, where the participants were followed 10 years after conclusion of the study, it showed that the HbA1c levels of the intensive control group and the conventional control group gradually reached comparable levels. However, the beneficial effect of intensive glycemic control on preventing diabetes persisted years after the intervention had been terminated. That means the memory, you can say the legacy effect or the metabolic memory or the metabolic imprinting, which is a carryover effect of prior glycemic exposure on the later course of complications, was or rather is important, and tight control of diabetes pays off in reduced microangiopathy and atherosclerosis and other complications years later, even if control has subsequently become less intense. And if you see the biochemical basis of metabolic memory, then damaging effect of advanced glycation end products formation in long-lived protein molecules such as collagen with half-life of more than 10 years is probably the basis that as long as the body or the tissues are exposed to high glucose levels, the end advanced glycation end products or the inflammation keeps on damaging the tissues. And if the glycemic control is achieved nicely right from the beginning, then this exposure is not there and you have a better outcome in the long run. So, what should we then aim for? We should aim for individualizing therapy and glycemic targets, because in some people you may not require a very intensive control, like very old people, like people who are suffering from significant comorbid conditions like chronic kidney disease, advanced liver failure, or advanced heart failure, or maybe the terminally ill patients like cancer patients. So do not aim to aggressively control IME in this subset of the patients or somebody who is very frail. Then be aware of the side effects of anti-diabetic agents and prescribe them judiciously, and aim for comprehensive CV risk factor reduction, which includes blood glucose, blood pressure, lipids, and limiting tobacco use, as most patients with type 2 diabetes succumb to cardiovascular disease. We must aim for tight glycemic control from the beginning, and it's worth it in the long run. So these are the glycemic targets basically which one we have to achieve for the patients, where the fasting blood glucose has to be maintained between 80 to 130 milligram percent, and our RSDI recommends is less than 115. The postprandial has to be maintained less than 180 by ADA and by less than 160 by RSDI, and HbA1c should be maintained equal to or less than 7 as recommended by both the bodies. So coming to the treatment part, basically, if we have people must have attended the etiopathogenesis and the classification of diabetes classes which were held, and we should target basically the site, the etiopathogenesis, and the site of action of oral anti-diabetic agents. You can see over it. This is the ominous octet you can see over here, which explains the etiopathogenesis of diabetes, and you see how different drugs are targeting these pathogenic mechanisms. So alpha glucosidase inhibitors, it acts at the level of glucose absorption. Then a DPP4 inhibitor and GLP-1 receptor agonist, which targets a decrease in creatine effect. Then you have pioglitazone and metformin, which is targeting increased lipolysis. Then SGLT2 inhibitors, which acts at the kidney and it targets the increased glucose reabsorption. Then you have again metformin and pyridine acting on insulin resistance at the level of the muscles and targeting the decreased glucose uptake. Then you have drugs like bromocriptine, which is a tries to correct the neurotransmitter dysfunction and the circadian and the hormonal rhythm of the brain. And the metformin and thiazole pioglitazone again acts on the liver basically, and they try to reduce the hepatic glucose production. Talk about DPP4 and GLP-1 receptor agonist again, then they have an action on the islet alpha cell, and they try to reduce the increased glucagon secretion. And finally, you have sulfonylureas or non-sulfonylurea secretagogues like meglitronide or repaglinide, and DPP4 inhibitor and GLP-1 receptor agonist, which are basically stimulating the islet beta cells, and they try to cover up the impaired insulin secretion from the beta cells of the pancreas. So this is the list of anti-diabetic agents available in India. You can see the metformin, which is the first line recommended therapy for type 2 diabetes until unless it is contraindicated. And then you have insulin secretagogues like sulfonylureas, where you have the first generation like glibenclamide, which is a long-acting drug. And then you have a newer generation like glipizide, then gliclazide and glimepiride. And the last two ones are the third generation sulfonylureas and are being used maximally. Then you have non-sulfonylurea secretagogues, repaglinide, netaglinide, and then you have thiazolidinediones, and which the you have pioglitazone, and now off late we have lobeglitazone also available. And previously rosiglitazone, troglitazone were there, but they've been withdrawn because of the side effects. And then there is alpha glucosidase inhibitors, where you have acarbose, miglitol, voglibose. These are three agents. And then DPP4 inhibitors, or you can call them gliptins also. And you can see here the sitagliptin, the sexagliptin, the vildagliptin, the alogliptin, Lena, teneligliptin, evogliptin. And shortly you will have some more gliptin also, very shortly, like prelagliptin, which can be used once a week. Then you have SGLT2 inhibitors, the most recent oral anti-diabetic drugs, you can say, and you have canagliflozin, dapagliflozin, empagliflozin, and rimogliflozin. And shortly, we will have extension in this class of drugs also, and like we will have sotagliflozin very soon. And then you have GLP-1 receptor agonist, which are although injectable, uh, most of them. So you have exenatide, which was the first one to came, and then we have liraglutide, lixenatide, dulaglutide, semaglutide. So these are the drugs, and out of this, the semaglutide injectable is not available in India. And the advantage with these class of drugs is the weight loss which they can achieve. And then you have the GLP-1 receptor agonist, which is oral. It is the only oral GLP-1, that is semaglutide, or we can say Rybelsus. And then you have other agents which have different actions, and they've been used as the anti-diabetic agent, although they may not be recognized or approved by the global agencies like USFDA and the European agencies. But hydroxychloroquine, saroglitazar, bromocriptine, colcivalin, and imeglimin. So these are the drugs. And finally, you have insulin, which can be used in any patient of diabetes, whether it is type 1 or type 2 or type 3. uh, and it can be used for, this is a drug basically which can be used in children right up to the old age, in pregnancy, and is the ideally the best suited drug because it's the natural hormone which is deficient in the body. So coming to the first class of drugs, metformin. So it's basically, you must have heard about the French Liliac, and it was used for treatment of diabetes from ancient times and contains the biguanide guanidine. And the first congener was penformin, introduced by in 1950s, but it was banned due to risk of lactic acidosis. And metformin, a safer congener of penformin, it was introduced in late 1950s, and now it is the most widely prescribed anti-diabetic drug in the world, and it is recommended as the first line drug for managing type 2 diabetes until and unless it is contraindicated, obviously after exercise and lifestyle. So primary action is on the liver. It reduces hepatic glucose output. Exact molecular mechanism is still unclear, but it activates the CAMP kinase, which is the fuel sensor of the cell in the mitochondria, and it inhibits the mitochondrial glycol 3-phosphate dehydrogenase and thereby decreases hepatic gluconeogenesis. It improves tissue sensitivity to insulin, increases peripheral glucose uptake, decreases intestinal absorption of glucose, and it has additional effects like it reduces appetite, it causes weight loss, it reduces the blood pressure, and it improves the lipid profile. So, given all these benefits, or you can say the merits, it has been placed on the top of algorithm where it has been indicated as the first line agent to be prescribed to type 2 diabetics. If you see the anti-diabetic efficacy of metformin, then it decreases fasting plasma glucose by around 60, reduces HbA1c by 1.5 to 2%, and hypoglycemia. The best part is that the hypoglycemia rates are similar to placebo when used as monotherapy. So, by its own, metformin will not cause hypoglycemia until unless it is combined with glimepiride or any other strong agent. And given the benefits of metformin, it's the first line agent for type 2 diabetes as per the most guidelines, and is also shown to prevent progression of impaired glucose tolerance to diabetes. That means it stops or reduces the progression from pre-diabetes to diabetes. Metformin is contraindicated in impaired renal function, that is EGFR less than 30, heart failure requiring hospitalization, hepatic insufficiency, alcohol abuse, use of iodinated contrast materials for radiological studies, known hypersensitivity to metformin, acute or chronic metabolic acidosis, including diabetic ketosis. So these contraindications they should be taken care of, and anybody who is on metformin and gets seriously ill and getting admitted to hospital, then we should withhold the metformin. And if there's somebody is having impaired renal function, then also we have to stop it. Same holds for severe liver disease, and concomitant alcohol abuse can lead to lactic acidosis. So one should be careful while consuming alcohol with metformin in large quantities. days. So this is the word about the use of metformin in renal insufficiency. And if the EGFR is more than 60, then no renal contraindication to metformin. Monitor renal function annually. We all know that normal EGFR is 90 to 120, and how you grade the chronic kidney disease based on EGFR rather than the creatinine levels. If it is between 60 and 45, then you can continue using metformin and increase monitoring of renal function, that is every 3 to 6 months. When the EGFR falls to 30 to 45, then prescribe metformin with caution. Don't start it in new patients, and you can lower down the dose, you can monitor the patients, and you can continue the metformin. But if it is less than 30 EGFR, then metformin has to be stopped. Side effects, they are minimal, and there are various preparations of metformin available. The normal preparation and the sustained release preparations, the slow release preparations. The slow release preparations reduces the side effects of metformin, and the common ones are diarrhea, abdominal discomfort, nausea, metallic taste, and anorexia. So these effects can be minimized by starting with a low dose and gradually up titrating the dose, and using the metformin after meals, that is after dinner and lunch, or maybe after breakfast, and using these sustained release preparations. Mild vitamin B12 deficiency can occur when metformin is used for a long time. So it is more than 2.5 times more likely than in non-users, and the prevalence is around 20% after 10 years of use. So B12 levels needs to be checked in long-term user, that is 4 years of use. Lactic acidosis is very rare and happens when there is a concomitant use of alcohol, or there is a liver or kidney failure, or in the CVLL patients. And patients on some sustained release preparation metformin occasionally report passing apparently intact tablets in the stool, which are ghost tablets. So this is a harmless phenomenon. It happens because sustained release preparation of metformin uses a shell of tablet where the drug of metformin gets released from that shell slowly, and that entire shell passes off intact in the stool. So let's see a case over here where a 52-year-old male is newly diagnosed with type 2 diabetes, a BMI of 31, fasting plasma glucose of 184, PP is 240, HbA1c of 8.9. So what will be your line of management? And when would you like to reverse his glycemic control? So in such patient, obviously the first recommendation would be the diet, exercise, and the lifestyle of the patient. And since the BMI is on the higher side, so we'll counsel the patient or explain the patient about the importance of weight loss over here. And after doing that, since the HbA1c is 8.9 and the sugar levels are quite high, so the first line management over here would be starting the metformin. And we all know the dose of metformin, so we can give it in 500 milligram starting dose as a starting dose, and can go up to 2 grams or 2.5 grams rather per day in divided doses. So coming to next class of drug, that is sulfonylurea. So after metformin, these have been the most commonly used oral anti-diabetic agents in India, especially over the last few decades, and they are still being the top ranking drugs which have been used for managing type 2 diabetes. So basically, they are derivatives of sulfonamide, and they were actually found to reduce blood glucose levels way back in 1942. And the fully mechanism was understood because sulfonamide, they were used basically as an antibiotic and antiseptic drugs, and they were found to show the hypoglycemic effects. And later on, as these time passed, so they were these derivatives of sulfonamides were discovered, and for targeting the beta cells to induce insulin release, and were used for glucose control. So if you can see the mechanism of action of sulfonylureas, they bind to the sulfonyl receptor on the potassium ATP channel of the pancreatic beta cell and close it, leading to depolarization of the cell and opening of the voltage-dependent calcium channels, and thereby release of insulin, which is stored in the beta cells. So we see the pharmacokinetic properties of sulfonylureas and different ones. So the glibenclamide, the drug half-life is a long-acting drug. Half-life is 8 to 12 hours and duration of action is almost 24 hours, and daily dose is 2.5 to 20 milligrams, and hardly you will require more than 10 milligrams a day. Glipizide is it's a shorter acting drug slightly, and with a half-life of 1 to 5 hours and duration of action 12 hours, and it has to be used in a twice a dose, and the dose has been wrongly imprinted over here, but the dose is normally 2.5 to 20 milligram. And then you have glycoside. The half-life of 6 to 15 hours, duration of action is 10 to 15 hours, and the dose is 40 mg to 320 milligram. And if you're using sustained release preparations, which are better nowadays available, then the dose you can use in the reduced doses also. Glimepiride, the half-life is around 5 hours, the duration of action is around 16 to 24 hours, and daily dose is 1 to 8 milligram. In general, the maximum effective dose is 50% of the maximum marketed dose. So what are the contraindications of sulfonylureas? The contraindications are hypersensitivity to the drug, renal insufficiency. Glipizide can be used up to EGFR of 30 where no dose adjustment is required. However, if it falls below 30, then caution is required. Gliclazide up to EGFR 30, no dose adjustment, and below that, use half dose or maybe lower dose. Glimepiride, EGFR less than 60, use with caution, and if it falls below 30, then it should be stopped. And glibenclamide has to be avoided in renal failure because it's a potent and long-acting drug and has the, the propensity to cause hypoglycemia. Then severe hepatic failure, then sulfonylurea should be avoided. Pregnancy, again, immediately following acute coronary event, type 1 diabetes and diabetic ketoacidosis. We should not use sulfonylureas. If you see the side effects of sulfonylureas, they can initiate insulin secretion independent of the ambient glucose levels. So that means whatever is the level of the blood glucose, if somebody is taking sulfonylurea, they, it will lead to lowering of the blood glucose. So hypoglycemia is a common side effect, and older agents like glibenclamide can produce strong hypoglycemia because they are potent and they are long acting. So to minimize the risk of hypoglycemia, the sulfonylurea should be started in the lower doses and they should be stepped up gradually. And the weight gain is again a side effect of sulfonylureas because they induce insulin release, and we all know that insulin is an anabolic hormone and it causes weight gain. Then hypersensitivity reactions, which although are rare but can happen because they are sulfur derivatives, so Steven-Johnson-like syndrome can happen with sulfonylureas. The next class is non-sulfonylurea secretagogues, and there are two drugs here, netaglenide and repaglenide. They are structurally unrelated to sulfonylureas, but both drugs share a common point of interaction on the sulfonylurea receptor 1 subunit of ATP sensitive potassium channel, which is distinct from the sulfonylurea receptor. They are mild agents, they reduce HbA1c by 0.5 to 1%, and they have minimal effect on fasting plasma glucose because they are very short acting. So their main role is basically to take care of the postprandial hyperglycemia, and they're useful in individuals who basically eat twice a day, and the consumption of carb or heavy meal is there. If you see the daily dose, repaglinide is 0.5 to 4 milligram and netaglinide is 60 to 180 milligram to be taken before meal and can be used as monotherapy or as combination with metformin and other OADs. Repaglinide can be used in renal failure. If you talk about alpha glucosidase inhibitors, these are the three drugs in the class: the carbose, miglitol, and voglibose. If you see the mechanism of action of alpha glucosidase inhibitors, then you can see here in the intestine and the level of enterocyte, they are basically acting or blocking the enzyme alpha glucosidase inhibitor, and they alpha, alpha glucosidase, sorry, and they will lead to retarding the absorption of disaccharides from the intestine into the bloodstream. So this is the graph. You can see the carbos and the carbohydrate absorption. That what happens after meal. You see the yellow line over here. This is the absorption pattern of carbohydrates when meal is taken. But if somebody has taken alpha glucosidase inhibitors like carbos over here, then it will blunt the absorption of carbohydrate from the intestine as shown by the red line over here. There is no peak after having meal. So in the jejunum, the basically duodenum, jejunum, and ileum, all parts basically, mainly in the jejunum, the absorption is reduced, and the usual dosage of carbos is 50 milligram thrice. That is just before every major meal like breakfast, lunch, and dinner. And the hypoglycemic potency is 50% that of sulfonylurea metformin. Since the GI tract is having high glucose load or the carbohydrates, therefore patients can have side effects like flatulence, bloating, and abdominal discomfort. They are most useful in patients who consume dietary and complex digestible carbohydrates, and they can reduce the A1C by 0.5 to 1%. The reduction in the peak postprandial glucose is by to the tune of 20 to 80 milligram percent, and you have to avoid in patients with chronic intestinal disease and advanced chronic liver disease. And adverse reaction can be minimized by starting with a low dose and up titrating slowly. The dose carbos we have already seen is 50 milligram, 25 to 50 milligram thrice a day, and miglitol is almost same. Voglibose can be given in the dose of zero point 0.2 to zero point 0.3 milligram before each meal with a maximum of zero point 0.9 milligram per day. And these drugs are to be administered along with the first bite of the food, and miglitol and voglibose are better tolerated than acamlos. The bloating and the flatulence which happens because of these drugs is best in voglibose and miglitol as compared to acamlos. Coming to another class of drugs, that is thiazolidinediones or pioglitazone. Uh, Mechanism of action, we all know they are insulin sensitizers basically. Main action is to increase glucose uptake into the skeletal muscle by increasing synthesis of GLUT4 and its translocation to the cell surface. So GLUT4 is the receptor which is responsible for glucose uptake in the muscle cell. It also reduces plasma non-esterified fatty acid concentration by promoting cellular uptake and triglyceride synthesis. If you see the biological actions, they are activators of PPR gamma, that is peroxisome proliferatory activator receptor, the nucleus of the target cell, especially the skeletal myocytes and adipocytes. They enhance sensitivity to insulin. So whatever insulin is being circulated in the body, it becomes more effective. They promote adipocyte differentiation. They promote uptake and storage of free fatty acids and enhance storage in subcutaneous fat vessels. That is why the body weight, or you can say the subcutaneous fat, it gets increased when one is using pioglitazone. But the good part is that subcutaneous fat is increased and not the visceral fat. We all know that visceral fat is dangerous for diabetes and metabolic problems, whereas subcutaneous fat is not that dangerous. It reduces triglyceride and free fatty acid levels, which reduces insulin resistance and leads to an increase in glucose uptake. Decreases tumor necrosis factor alpha expression, which is an inflammatory marker. That means it has an inflammatory action. It has no action on insulin secretion. Or if at all it is there, it is very less, but otherwise it is not. It's not an insulin secretagogue, and it regresses the progression of carotid intima media thickness. That means that it is having a better effect on the endothelium or the blood vessels, and thereby can have beneficial effects on the cardiovascular side effects or outcomes in long run. If you see the side effects of pioglitazone or maybe lobeglitazone, which is now available, then weight gain because it leads to increase in the subcutaneous fat tissue. Fluid overload, fluid retention is another side effect, and we should be cautious because, especially in the patients of heart failure and kidney failure, where the fluid overload can worsen the situation. Then pedal edema because of the fat and the fluid retention, risk of fracture, especially the hip fractures, and on the prolonged use, especially in the post-menopausal females, mild lowering of hematocrit, probable increased risk of diabetic macular damage. So, somebody complaining of sudden blurring of vision or altered vision and on pioglitazone, one should always go for a fundus examination. And increased risk of bladder cancer, there have been various reports about these, but they have been refuted in the subsequent meta-analysis where the causal relationship could not be established with the use of pioglitazone. But the concerns were raised especially when pioglitazone was consumed for a long time, especially in elderly males. If you talk about the anti-diabetic efficacy, the only type available in India is was pioglitazone, but nowadays lobeglitazone is also there, and the dose is 7.5. Again, is not available pioglitazone, but 15 and 30 milligram strengths are available, and the maximum dose can go up to 45 milligram, and can be given once a day without reference to any meal timings. They are slow acting drugs, and the effects are seen only after 2 to 3 weeks, and it takes 2 to 3 months to achieve maximum benefit with pioglitazone. So, so one should be watchful when using pioglitazone that their maximum efficacy will take time, and we should up titrate the other drugs slowly. Otherwise, after 2 to 3 months, patients may land up into hypoglycemia. It can bring down HbA1c by 0.5 to 1.5%, and it has favorable effects on lipid profile. If you talk about lobeglitazone, the dose is zero point 0.5 to 1 milligram per day. Contraindications with class 3 and class 4 heart failure. In pregnancy, it is contraindicated. It is best avoided in moderate to severe renal failure because of the risk of fluid overload, and to be used in caution with patients of anemia, with fluid overload because of any etiology, postmenopausal women because of risk of fractures. You cannot use it for a long time. And then those who are having retinopathy, especially those who are complaining of blurring of vision because of macular edema, and uh, uh, so, regarding the risk of bladder cancer with pioglitazone, the government of India has recommended the following: it should not be used as the first-line therapy for diabetes, especially in the elderly males, and those who have active bladder cancer, those with unexplained hematuria, should not receive pioglitazone. Safety and efficacy of pioglitazone to be reviewed after 3 to 6 months, and the drug stopped in those in whom adequate response is not seen, and known risk factors of bladder cancer to be assessed before starting pioglitazone, and pioglitazone to be used with caution in elderly. So let us see another case where there is a female 56-year-old lady, type 2 diabetic for 6 months, lifestyle modification and metformin 1000 milligram a day, and she comes to hospital for a follow-up visit. And her weight has decreased from 78 to 676, and her height is 158. A1C is decreased from 8.9 to 7.9. So, what will be the further line of treatment? Although she is on metformin and lifestyle modifier. Still, the HbA1c is high, which is 7.9, and she is losing weight. So something needs to be done to this patient. Some other drug needs to be added, and we sorry. So we come to another class of drugs, that is the incretin mimetics, right? In view of the case which we have just discussed, we are discussing this class of drug, incretin mimetics, right? So what are incretins? Basically, they are GLP-1 and GIP, the hormones secreted from the gut mucosa in a response to a meal. As soon as you eat, these two hormones are released in the gut mucosa, and they act by binding to receptors on the target cell surface. And the main target tissues include pancreas, GIP, and CNS. They enhance insulin production and secretion when they bind to the pancreatic beta cells, and they increase islet cell mass in the animal studies, and they slow gastric emptying, they suppress appetite, and they inhibit glucagon secretion and suppress the beta glucose production. In the absence of glucose, incretins cannot initiate insulin secretion, and their action is said to be glucose dependent. And that is the best part with these class of drugs. Whenever there is a glucose load in the intestine, incretins will be secreted, and they will lead to or the insulin secretion from the pancreas, and thereby leading to reduction in the glucose levels. So this is the mechanism where how the different drugs are acting on the pancreatic beta cell. You can see the sulfonylurea or meglitide, how they are acting on the sulfonylurea receptor, and then the GLP-1 or the GIP, how they are acting on the pancreatic beta cell, and they were triggering the release of insulin from the beta cells. This is the incretin effect, which is demonstrated in response to oral versus IV glucose. So, if you give the IV glucose, basically, then the gut is bypassed, and you will not have any incretin effect. That means the GLP-1 and the GIP will not be released to that tune. But as you eat, or there is a glucose load in the intestine, the incretins will be there, and it will lead to control of blood glucose. So this is how the incretins have their role in glucose homeostasis. As soon as the food is ingested, so release of gut hormones. But the unfortunate part is that these both the drugs, the GLP and the GIP, they are very short-acting drugs, and they are deactivated very quickly by an enzyme which is called as DPP4, that is dipeptidyl peptidase 4 enzyme. So if you have a drug which targets this DPP4 enzyme and blocks it, then probably you will have higher circulating levels of GLP-1 and GIP after ingestion of food, thereby enhancing the insulin release and glucose control, especially in the postprandial state. So GLP-1 and GIP are not therapeutically useful since they have short half-life as they are rapidly inactivated by DPP4 enzyme. The currently available GLP-1 receptor agonists have longer half-life than native GLP-1, and as they are resistant to degradation by DPP4. So whether you talk about the liraglutide, exenatide, dexenatide, dulaglutide, they all are the GLP-1 receptor analogs, and they are having long half-life. So this is the comparison of available GLP-1 receptor agonist, right? So you have whether exenatide, which is a long-acting exenatide, which can be used once weekly. Then you have liraglutide, which is used once daily. Then dulaglutide again once weekly. Lixisenatide once daily. And semaglutide again is once weekly. And then you have oral semaglutide also, where you have to use in dose of 3 milligrams, 7 milligrams, 14 milligrams, which is escalated gradually. So, as far as the renal dosing is concerned, majority of them they don't require any dose change except for exenatide, and the drug can be taken irrespective of the timing of the meal. And the only precautions or caution with these class of drugs is the pancreatitis. If somebody is suffering from pancreatitis, one should not use, or thyroid, C cell cancer, or anybody suffering from ME and type 2, then one should not use them. With semaglutide, one should monitor for retinopathy progression. So if we talk about the GLP-1 receptor agonists, the clinical pharmacology says that the expected HbA1c reduction is 0.5 to 1%. They produce weight loss, and they predominantly are excreted by kidney, and they are given as subcutaneous injection, except semaglutide, for which an oral formulation is also available. And recently, a dual GLP-1 GIP agonist, tirzepatide, has been introduced globally, and it is around to be around the corner in India also. And contraindications to these class of drugs is hypersensitivity, then type 1 diabetes, then end stage renal disease, severe renal impairment for some agents, not for all, severe GI disease and pancreatitis, medullary thyroid carcinoma, or multiple endocrine neoplasia syndrome type 2. The advantages of GLP-1 receptor agonist are it has a glucose dependent mode of action. So whenever the glucose levels goes up, especially in the postprandial state, these drugs will work. Otherwise, they will not work. So there is a very low risk of hypoglycemia when they are used as monotherapy or along with insulin sensitizers. Then weight loss. We all know the global phenomena of how the GLP-1 receptor have been used as an off-label indication also for reducing weight loss in obese patients. And then liraglutide, semaglutide have shown favorable cardiovascular risk profile, especially in the atherosclerotic heart disease, and they have been approved as second-line agent after metformin for all patients of type 2 diabetes. May be considered even as first-line therapy in those where the established atherosclerotic cardiovascular disease or chronic kidney disease is there. We talk about the side effects, then nausea, vomiting, headache, tachycardia, pancreatitis. So mainly GI side symptoms, loss of appetite. Then they have been approved by USFD as monotherapy or in combination with other agents. Coming to next class of drug is DPP-4 inhibitor, which again work on the incretin axis. So first class of drug working on incretin axis was GLP-1 receptor agonist, right? They mimic the action of GIP and GLP-1. The DPP-4 inhibitors, what they do is they inhibit the enzyme DPP-4, thereby prolonging the action of endogenous GLP-1 and GIP. And these are the different gliptins, which we have already seen: the sitagliptin, the vilda, sexagliptin, alogliptin, linagliptin, telenli, and avogliptin. And you can see the pharmacokinetic profiles of different kind of gliptins over here. And we all know we have been using all these gliptins for quite some time, almost now. And in India, they were launched way back in 2008, and almost now 17 years in India. And with the sitagliptin, vildagliptin coming first, and followed by the all others. And they are oral drugs, can be administered with or without food, can be used as monotherapy or in combination with insulin sensitizing agents or insulins. And while combining with sulfonylurea, reduce the dose of sulfonylurea by 50% to reduce the risk of hypoglycemia. They increase the circulating levels of GLP-1 and GIP, decreases glucagon concentrations, increase plasma levels of insulin and C-peptide, and they primarily decrease the PPG, that is the postprandial blood glucose, and HbA1c reduction of 0.5 to 1%, or maybe even more, depending on the baseline HbA1c, can be achieved. The dosage you can see over here: sitagliptin is 100 milligram OD, Sexa is again OD, alogliptin is OD, linagliptin is OD. Vildagliptin is the only gliptin which is to be used in twice a day dose, but now the sustained release preparations are available which can be used once a day. Teneligliptin again is OD and Evo. So you have ease of use with these drugs. Once a day, they mainly act on postprandial blood glucose. The they don't have any major risk of hypoglycemia until unless they are being used with other secretagogues like sulfonylureas or maybe insulin. And dose adjustment is needed in renal insufficiency for sita, sexa, and vildagliptin and gliptin, whereas lina and teneligliptin can be given without dose adjustment. They are very well tolerated drugs, and rarely can produce common cold-like symptoms and nausea. Incidence of hypoglycemia is similar to placebo when used as monotherapy. A few cases of acute pancreatitis have been reported during post-marketing surveillance of sitagliptin, and however, the causal relationship has not been established. And rare adverse events include joint pains and bullous pemphigoid. And long-term cardiovascular outcome trials have shown increased risk of hospitalization for cardiac failure with sexagliptin and some extent with alogliptin, but no CVOT data available for Vildat and alogliptin, and neutral results for other DPO. So that means they are cardiac neutral drugs. So they don't have any side effects on the cardiovascular system. So let's see another case. Is a 43-year-old male have diabetes, right, with family history, and the blood pressure is normal. Weight is 90 kgs, and the BMI is 33. The fasting glucose is 180 and PP 270. HbA1c is 7.8, and there are no ketones. So how would you manage these patients? It's a very common profile, but the only thing is weight is very important over it. You have to choose a drug which either is weight neutral or which can induce weight loss. Another case study, a 73-year-old male without previous history of diabetes, and physical examination shows 110 by 70 blood pressure, weight is just 60 kgs, and investigation shows the fasting plasma glucose is more than 200 and PP around 320 with a high HbA1c. So how would you manage diabetes over here? So the points to be noted over here is that the age is 73. So you have to choose a drug which does not cause hypoglycemia. Number one. Number two, this patient is already having weight of 60 kg. That means he is underweight and blood glucose are still high. So we have to choose, or we can choose a drug which does not cause hypoglycemia. However, this patient can afford to gain some weight, which otherwise also he will get once the blood glucose is controlled. So another patient, so 45-year-old overweight businessman who travels frequently and has diabetes for 5 years, presents with uncontrolled blood glucose, and he's already on glipizide twice daily and metformin twice daily. Still blood glucose is fasting 225 and PP 302, A1C is 9.7, so grossly uncontrolled, and he does not have any evidence of any chronic diabetes complications. So what will you advise to this patient? So this patient is already long-standing diabetic because 5 years have gone. He's young, he's already on two drugs, but grossly uncontrolled. So probably you will require drug which either is very potent to bring HbA1c from 9.7 to 7, and probably the usage of insulin probably would perhaps be the best in such situation. So coming to the last class of oral diabetic drugs, that is the SGLT2 inhibitors, which is a blockbuster, you can say, oral antidiabetics, which we have been using in last almost 8 to 10 years now. And what are SGLT2 inhibitors? Basically, it's a sodium glucose cotransfer protein found in the renal proximal convoluted tubule and enterocytes in the intestine, which is responsible for reabsorbing the majority of glucose present in glomerular filtrate as well as intestinal glucose. So SGLT2 are in kidney and SGLT1 are in intestine. And currently available agents in this class are highly selective inhibitors of SGLT2. That means they are acting on the kidney and not in the intestine. So these drugs reduce hyperglycemia by promoting the loss of glucose in urine. So this is the diagram of the proximal convoluted tubule cell. You can see over a PCT cell where you have tubular lumen on the left and the interstitium on the right. And this is how the SGLT2 inhibitors, they are preventing the reabsorption of glucose from tubular lumen into the PC proximal convoluted tubule cell and thereby in the interstitium. So if this absorption, or you can say reabsorption, is inhibited, the glucose will pass out or will be flushed in the urine. So they bring about a reduction in HbA1c of 0.7 to 1% compared to placebo. They have minimal risk of hypoglycemia. Why? Because if their circulating blood glucose is high, then only it will be filtered out in urine, and otherwise if the blood glucose is normal, so SGLT2 inhibitor will not have any effect. So those ranges are different for different class of different drugs. So for Cana it is 100 to 300. For dapagliflozin it is 5 to 10 milligram per day, and for empagliflozin is 10 to 25 milligram per day as a single daily dose, and remogliflozin is to be used in twice a day dose, that is 100 milligram twice a day. And recent evidence have suggested that these are the agents which can be safely used in patients with EGFR of more than 20, although full anti-hyperglycemic efficacy may not be seen below EGFR of 45. Side effects, they are generally well tolerated, and adverse effects include genital mycotic infections. 11% higher in women and 5% higher in men compared to placebo. And why? Because there is passage of glucose in the urine, and this glucose, it gets deposited sometimes on the genitalia and the skin, and it can then lead to fungal infections quite commonly. Then if you talk about the urinary tract infections, then rarely urine infections can also be there, and but it is the genital mycotic infections which are much more commoner. And uh, because what happens is, as glucose is being flushed out in the urine, so it leads to osmotic diuresis. So sometimes the volume depletion or dehydration can occur, so one should be cautious, especially those who are drinking less water or in the elderly population, where the chances of having dehydration are very high. So as far as lipid profile is concerned, they are by and large neutral because they increase both HDL and LDL, so the ratio almost remains same. And the occasional reports of euglycemic ketoacidosis uh, have been reported, especially in those people who are not eating properly or those who are type 1 diabetics. As of now, these drugs are licensed only for use in type 2 diabetes and not type 1 diabetes. Coming to the miscellaneous agents, bromocriptine. Use of low dose quick release bromocriptine within 2 hours of awakening has been shown to reduce post meal glucose levels due to suppression of hepatic glucose output. They are indicated in type 2 diabetes treated on diet alone or with sulfonylurea, metformin, or pioglitazone, who are not at target. Dose is zero point 0.8 milligram, and they are very mildly effective drugs, and they can reduce HbA1c by 0.4 to 0.7%. The next is hydroxychloroquine, which is a derivative of quinine, which is mainly used as a anti-rheumatic drug, basically for treating rheumatoid arthritis, where it causes hypoglycemia. Dose is 400 milligram once a day, and can reduce HbA1c by 0.5 to 0.6%. And however, patient has to be monitored for retinal toxicity. Then you have saroglitazar, which is an Indian invention, which is a novel lipid and glucose lowering agent both, and it acts on dual PPR alpha and PPR gamma, and the predominant effect is on PPR alpha, thereby it favorably alters the lipid profile, and then also has effect on glucose also. They are mildly effective with a HbA1c reduction of 0.5 to 0.8%, and they decrease plasma triglyceride level. Dose is 4 milligram OD, and they're very well tolerated, except for few side effects like GI symptoms and dizziness. Then you have colcivelum, which is a bile acid binding resin used in treatment of hypercholesterolemia, can also reduce blood glucose levels by effects on the farnesoid X receptor. This is the bile acid receptor, and they also increase GLP-1 levels. They again are very mildly agents which reduce HbA1c by 0.3 to 0.5%, and dosage is 3.75 gram OD. And side effects are mainly gastrointestinal, that is constipation and flatulence. So these miscellaneous agents, they are basically indicated in special situations and as an adjunctive or adjuvant treatment to the mainline treatment. And then you have the last one, that is the imeglimin, which is a novel oral antidiabetic agent recently approved in India, which is a mitochondrial modulator and has an action almost similar to metformin, which inhibits oxidative phosphorylation and thereby blocks gluconeogenesis in liver and increases glucose uptake in the skeletal muscle. It also has anti-inflammatory effects, and the dose is 1 gram twice a day. So with that, we come to the end of the presentation of oral anti-diabetic agents. And in the second part, we will have an exclusive discussion on usage of insulin for managing different type of diabetes, that is both type 1, type 2, and use of insulin in acutely ill and hospitalized patients and during surgical procedures. Thank you very much, and I hand over the mic to the ICP team. And if there are any questions or queries or comments, then we can discuss. Thank you very much.
Sir, do we have to write the questions in the chat box or we can ask?
You just put the questions in the chat box. I'm going to reply that.
Thank you.
एक घंटा 20 मिनट हो गए ऑलमोस्ट 10 मिनट 5 मिनट लेट चालू किया था 1 घंटा हो गया पूरा I cannot see any question in the chat box, so I think we can sign off. Then the next Monday, I will request all the participants to attend the class so that we can have a very healthy discussion on insulin.
Sir, I have added the question. I'm so sorry to bother you.